one of the problems, of course, is especially in pathology that we are extremely material dependent. So if we do not have good material, especially for the biopsies, especially in the upper urinary tract, it can be extremely tricky for us. And cytology is helpful, but is for sure not the thing which will sort out everything. And then another problem is that of course, we have limitations with regards to the bladder wall, for example, if you do staging in the bladder, because the bladder wall does not look the same everywhere. You can sometimes even have, very small lamina propria. You can have fat between the lamina propria and the muscle. So you must be very, very careful what you say in your report, even if you have the impression there's more in it. Another thing is that it is not always black and white. Even if you cut deeper levels, sometimes you will not be able to be 100% sure that this tumor is really muscle invasive, for example. So this is something which is really very tricky. There are several, of course, discussions in pathology about substaging, for example, in the bladder, the T1 tumors, because we think everybody thinks that it's pretty important to do some substaging, because the more the tumor is invading the lamina propria, of course, the more it's probably aggressive. But we do not have a perfect standardized method. So some people do the A method, others do the B method. So it's not always obvious to be in accordance with everybody. So WHO since 2016, of course, recommends to do the substaging. But as I told you, there are two major systems which probably are recommended, more or less recommended, but no official recommendation exists. And then, of course, we have still the problem with sometimes, with the Interobserver variability, because sometimes, for example, T3A tumors is a tumor which is invading the perivesical fat in the bladder. But sometimes you have this kind of inflammatory fibrosis around the tumor. So you don't really know, is this already invading the fat and is it just reactive desmoplastic stroma around, or is it still in the bladder wall? So here we have some discordances, and this is, of course, important, not so much for the staging, but it's important for the prognosis of the patient. So these are really things which are important with regards to, let's say, resection specimen, probably en bloc resection. En bloc resections is something which is very useful because we see very much of the tissue. We see very well the tissue. We do not have very many artifacts. So this is probably something which should really be upcoming in the next years. And more departments do these en bloc resections, which for us are really very helpful.